The patient is a 76-year-old homemaker living with her adult children. She has no known allergies. She is hypertensive and is on medication and has hepatitis B. The patient also has mild Parkinson's disease and is on anti-Parkinson medication. Her chief concerns include pain at the upper left tooth, difficulty in chewing foods, and would like to chew foods better. And but the problem is that she has sharp edges of teeth that occasionally cuts her tongue. She has lost her old denture some time ago and would like a new set of dentures, although she finds denture wearing particularly uncomfortable. On examination, the patient walks in with a slightly stooped gait and shuffles. She has uncontrollable hand movements but is still able to manipulate dentures and brush her teeth adequately. She stutters in her speech and has a persistent dry cough and has a history of gastroesophageal reflux disease and gastritis. She's currently seeing a gastroenterologist for that management. The occlusal movements are relatively smooth, but occasionally she has some muscular spasms. She is partially dentate with teeth 17, 16, 15, 14, 11, 23, 24, 26, 27, and all lower molars missing. She has a pronounced palatal torus. The remaining teeth shows signs of tooth surface wear, with some teeth, in particular the lower anteriors and 1-3, 1-2, and 2-1, showing near pulp exposure. There appears to be an over-eruption of the lower teeth with some compensation, which does not affect her facial third. The 2-2 is non-vital with pulp exposure and is abscessed. And there's also general subgingival calculus present in the dentition with a basic periodontal examination of 3. She has a peculiar dietary habit of enjoying drinking rice wine and fruit skin pickles. She brushes her teeth with a hard bristles toothbrush, and strangely no carious lesions are found. Diagnosis includes tooth surface wear with elements of attrition, abrasion, and erosion. The 2-2 is non-vital due to degradation leading to pulp exposure. 3-1 and 3-2 are possibly non-vital and sclerosed but have no symptoms. Discussion of treatment options are listed in the clinical write-up. The definitive comprehensive treatment plan will involve conservative treatment including an upper chrome cobalt removable partial denture and lower direct restorations for tooth surface protection with shortened dental arch concept applied. The first stage would be the control of disease and any other underlying conditions. Of course, we have to relieve the patient from pain where endodontic treatment of tooth 2-2 was carried out. Afterwards, a dietary analysis and cooperation with the home carer and the gastroenterologist and the management of polypharmacy medication is carried out, as it is known that all of the medications that were listed earlier on do have an association with reduced salivary flow and xerostomia. The oral hygiene instructions are then given, and then also the dietary habits were analyzed. A watched information form has been given to the carer so that she is able to monitor the patient's dietary habits. The preventive considerations were given, including preventive advice, dietary emphasis, lifestyle factors, oral hygiene advice, salivary protection, and other adjunct therapies, which includes sugar-free chewing gum, fluoride formulations, and fluoride varnish gels. It is very important to address the balance of the oral environment before proceeding towards the second stage of the treatment. The explanation of a patient's multifactorial tooth wear etiology in creating such a diverse variety and spread of lesions involves aspects that extend well beyond what examination of the dentition alone can determine, and they include the following: the role of intrinsic and extrinsic acids. In this case, acids from patient's diet and also acids from the patient's reflux. The role of attrition and abrasion, where patient uses a hard bristled toothbrush, and attrition because due to the lack of posterior support, the patient is forced to use the anterior teeth for mastication. The role of saliva protection, where there is a lack of saliva, there is a less salivary flow on the patient's mouth, and therefore the buffering action of saliva in the mouth is affected. The role of patient lifestyle, diet, and habits, as mentioned earlier on, the role of patient health and medications, and of course the variation of above all over time. The second stage of treatment is to restore form, function, and aesthetics. The treatment that we have chosen would be the treatment that has the most minimal intervention and is deemed as the most conservative possible, at the same time fulfilling the criteria of form, function, and aesthetics. The lower arch is only restored to the second premolar using direct composites, utilizing the SDA or shortened dental arch concept. We also keep the treatment simple with one less denture, as no lower removable partial denture is needed, and therefore free end saddle is best avoided. This is also indicative in the top arch. The top arch is restored with a metal framed removable partial denture to restore posterior teeth not beyond the most posterior teeth available in the patient's mouth. This would only be of a Kennedy Class 3 design that has the most stability and design and is based on the principle of support, stability, and retention, where direct retainers, they are present at all extremities of the denture, with the presence of reciprocal and retentive arms, and adequate occlusal rests have been made that rest on the amalgam occlusal platform of the posterior teeth. Cingulum rests are also present and they function as indirect retainers. The clasp arms provide adequate reciprocation and guiding plane, and all these have been designed and determined when the models have been surveyed. The metal frame denture also acts as a dial appliance, where supra-occluded 4-5 is slowly intruded via orthodontic means. In general, studies comparing people with a full complement of teeth with those with shortened dental arches have not demonstrated significant differences in the ability to chew. Among patients with the minimum recommended number of occlusal units, the insertion of a removable partial denture does not significantly improve oral function. Therefore, we avoid as said earlier on, the implementation of a lower double bilateral free end saddle. According to some studies, the more teeth missing beyond the minimum, however, the more difficult a person will have in chewing. In addition, those without molar support have not been shown to have a higher incidence of signs and symptoms of temporomandibular disorders. Similarly, the shortened dental arch has not been associated with significant discomfort, distress, or occlusal wear. In addition, the absence of multi-rooted teeth, namely the molars, will not give risk of developments of furcation involvements and reduce the risk of periodontal conditions. The maintenance for the patient is also much easier, as she does not need additional motor effort in keeping the posterior teeth clean. The patient failed to come back for almost a year later, where in the latest review, it was revealed that the patient was hospitalized often due to recently found peptic ulcer, and examination shows signs and deterioration of the lower restoration. This is possibly due to episodes of the patient's gastric attacks and reflux. The patient is now on antacids and also calcium channel blockers, and currently undertaking medication to address her stomach ulcer. The restorations were then refurbished, and some were touched up, and the denture was polished and maintained. The patient is still being reviewed and is being monitored for continuous care. However, once after the restorations and the dentures has been issued, the patient has expressed satisfaction and improvement in her chewing and ability to function